Hi guys, welcome back to Module 12. This week we are on to psychosocial problems. This is part one of the 2 weeks we're going to get into the psychosocial chapters. This week we're focusing on common psychosocial complaints, substance use disorders, schizophrenia spectrum disorders, mood disorders, anxiety, stress, and trauma-related disorders, as well as OCD or obsessive compulsive disorders. So again, I just like to go through the assigned readings just to pinpoint and make sure that I have you guys review certain things. Please do look at chapter 64 in your psychosocial complaints and review that advanced assessment of the DSM-5. I mentioned that last week. That is the book that has all the clinical diagnoses and requirements to diagnose any psychosocial issues. That is, you'll see throughout your textbook in the readings that they continually refer back to the DSM-5. So just please familiarize yourself with that book. You can just look it up online, or if you have any, just so you know what it is. Within each chapter, under each assessment of each particular complaint, they do go through the diagnostic criteria based on the DSM-5, corresponding with whatever complaint you're reading about. So just so you know what that is. In terms of depressed moods, please review your screening tools for the various mental health criteria, as well as understand and differentiate depression from grieving. And do look at your table 64.2 in terms of the different types of depression. We will go through this PowerPoint, and I will definitely go back and talk about Kubler-Ross and the stages of grief, just to remind you, and so that you can make sure you differentiate the two. We are going to get into the substance use disorders as well as intimate partner violence, also known as IPV. Please make sure you review box 64.1 on interventions for intimate partner violence for the APRN. In the substance use disorders chapters, we have a couple of clinical presentation boxes that just talk about substance intoxication withdrawal, as well as indications for inpatient withdrawal from substances. So you do need to be able to differentiate when it is you would hospitalize a particular patient with this disorder. You also want to review patient education in terms of substance use disorders on page 1082. We do get into schizophrenia in this PowerPoint. Please review table 66.1 in terms of the differentiating psychotic disorders, the symptom clusters of schizophrenia in box 66.1, as well as the drugs commonly prescribed in terms of typical and atypical antipsychotics. You want to review the extrapyramidal symptoms, as well as the patient education in terms of schizophrenia. That really goes hand in hand with the patient as well as the family or caregivers. In terms of mood disorders, we are getting into MDD or major depressive disorder. You're going to want to review the risk factors, the components of depression specifically in elderly, the drugs commonly prescribed, as well as patient education. Bipolar and related disorders, please review your dig fast mnemonic. That's in box 67.2, as well as being able to distinguish between bipolar and unipolar depressive episodes. You want to go through the management of bipolar disorder as well as patient education. Suicide, definitely get into that. We are going to talk about suicide in veterans as well as the elderly. There's a high prevalence for that with those two particular populations. You want to review the risk factors, including the mnemonic SAD persons in terms of doing suicide screening. You want to look at 67.4, the box, in terms of suicide assessment and management, as well as, of course, patient education. That's a big one. In chapter 68, we got into anxiety, stress, and trauma-related disorders. Just make sure you're reviewing your causes of anxiety medications, drugs commonly prescribed. Definitely reviewed box 68.3 in terms of cognitive behavioral strategies. You're going to hear a lot about that throughout this PowerPoint. So cognitive behavioral therapy, cognitive behavioral strategies, just make sure you review that. And in terms of panic disorder, you definitely want to look at the complementary therapies for panic disorders. Post-traumatic stress disorder, sexual assault, please look at the patient education in terms of sexual assault. We get into obsessive compulsive disorders in chapter 69. You definitely want to look at the table 69.1, in terms of the common symptoms of OCD and how it presents. You want to review the screening questions, differential diagnosis, and patient education for both OCD, body dysmorphic disorder, as well as hoarding disorder. The APRN practice guidelines in your CASH textbook all are listed. The guidelines we're going to review actually next week, but I did want to list it here for this week because they are listed in your readings. I'll list it again for next week as well. But next week we'll really review the guidelines specifically. Common psychosocial complaints. So here we go. So the first big thing you're going to see in primary care is stress and anxiety, right? Stress and anxiety, most common psychiatric disorders in the US. Anxiety is defined as an unpleasant state of physical and psychological arousal that interferes with effective psychosocial functioning versus your depressed mood. And usually a lot of the times these go hand in hand, of course. Depressed mood, you have to make sure to review your hallmarks of major depression, which includes sadness and apathy, as well as understanding the severe psychological pain and suffering that goes with a depressed mood. In terms of anxiety symptoms are typically manifested in several dimensions, including affective, cognitive, behavioral, and somatic. Effectively, anxiety is an experience of dread or foreboding or panic, often accompanied by autonomic hyperactivity, primarily sympathetic in nature, and it's manifested as bodily symptoms. So the patient may actually attempt to counter the affective component of anxiety by cognitive thoughts that seek to make sense or minimize the discomfort. Additional affective symptoms of anxiety include apprehension, fear, irritability, intolerance, frustration, overreaction, or hypersensitivity to personal feelings of shame. Behaviors such as avoidance, distractibility, and restlessness reflect the anxiety or may evolve in response to it. Behavioral symptoms of anxiety include apathy, compulsions, rigidity, overreactions, preoccupation, and repetitive actions such as hair pulling or nail biting. Somatic symptoms range in intensity from a loss of appetite, dry mouth, fatigue, diarrhea, sweating, chest pain, hyperventilation, vomiting, and paresthesias. Highly anxious people may experience the full range of anxiety symptoms or may have only one or two symptoms. The classification of anxiety disorders is largely based on clinical presentation. Okay, so just make sure you review that. In terms of depression, these are the depression treatment components. I love these little icebergs that your book provides. They are actually very thoughtful in the way they present it in terms of looking at the particular condition from a holistic standpoint. Here, they include your pharmacological components of depression and the major medications we use to treat with, which would include your antidepressants, your SSRIs, your tricyclics, your MAO inhibitors, and these could include your Buspar, your Trazodone, your Effexor, Remeron, and of course, you want to monitor for side effects and responses with these types of medications, as well as assess for suicidal ideation. The other components include your caring, your psychosocial, your complementary therapies, and your lifestyle issues that you want to deal with. So please review this. I would look at it in your book just so you can get a clear view of it. Suicide prevention. So when we're dealing with anxiety and grief and depression, we're also concerned, of course, with suicide. So keep in mind there's millions of resources out there for suicide, including the National Institute of Mental Health, which has a suicide prevention lifeline. Most states have their own suicide prevention hotline. So please make sure you have that information available in your practice, and you just make sure everybody is aware of it and that information is readily available for patients, so that if they have those, any of the symptoms that are like going to possibly even consider suicide or hurting themselves, that they know they have a resource to turn to without feeling judged. In here from the CDC as well as the National Institute of Health, they have tons of resources that are just little tools for both patients and professional practitioners to use in terms of screening. So I just wanted to make you guys aware of that. Feel free to check out those resources. Treatments for opioid overdose, withdrawal, and addiction. Again, National Institute on Drug Abuse. These are the meds you should definitely be aware of in terms of utilizing these for overdose or withdrawal. your methadone, your naltrexone, your bupropion. Just review these, your naloxone via the nasal spray. These are the drugs we would use if necessary. And again, these are resources that are available to you through the National Institute of Health. So when you're working, depending on which practice you're working in, you'll know where to go to have these resources available for you and your other practitioners. Common psychosocial complaints. So now we're going to get into grief as well as substance use disorders. In terms of grief, I just want to make sure that you are being very conscious of differentiating grief from depression. Okay, keep in mind grief can last from 6 months to a year. And I will go over the Kubler-Ross grief cycle on the next slide. Before we do that, I just wanted to talk about the substance use disorder. It's common neurophysiological basis to all addictive behaviors. And of course, we have an obligation as primary care providers to inquire about, provide information about, and make appropriate referrals if we do suspect a substance use disorder. Keep in mind the DSM-5 has diagnostic criteria specifically for substance use disorder, as you can see here in this box. So if we have 2 to 3 of these particular criteria, then it's considered mild, versus if we have 4 to 5, it's moderate, and 6 or more is severe. These are the criteria that would result in a diagnosis of substance use disorder. So number 1, taking the substance in larger amounts or for longer than you meant to. Number 2, wanting to cut down or stop using the substance, but not managing to do so. Spending a lot of time using, or recovering from the use of the substance, and so on and so forth. So these are the criteria for specifically substance use disorder. In terms of differentiating grief versus depression, please review the Kubler-Ross grief cycle. Okay, remember, denial, anger, depression, bargaining, and acceptance. All right. Grief and depression share many of the same characteristics, and it can sometimes be difficult to evaluate exactly when the scope of normal grieving has actually slipped into a pathological realm of depression. So it's important to distinguish the grieving process from a major depressive episode. The DSM-5 points out several features that help to define each process. In addition, an individual with a history of depression is at risk for depression during times of major loss. So these are the patients we're screening if they had a major loss, God forbid. The patients we know that already have a history of depression, we don't want them to go off the deep end. So these are the people we get in and screen and just make sure we give them any kind of support necessary to help get them through their time of loss. The mood disturbance in depression is typically pervasive and unrelenting, whereas fluctuations of mood and grief are more common. Early detection of grief and preventative interventions can alleviate suffering and lead to earlier and more effective treatment. This includes preparing, if possible, the person and family for the normal stages of grieving. So you're basically telling the patient that it's normal to grieve, like what you're going through right now is normal. And if you feel very depressed at times, again, that's normal. But then we get into the discussion of, okay, at a certain point, things will get better. And that's when you say to the patient, if it doesn't feel at any point it's getting better and it only feels like it's getting worse, that's when you need to come back and talk to me. Okay, that's, you really have to make that very clear. In the case of terminal illness, early and ongoing bereavement assessment and a collaborative process are essential components of a preventative approach to bereavement care. Interventions include bereavement education, counseling that assists in facilitating communication with the dying person. There is strong evidence that involvement and caregiving benefits the survivors as well. As primary care clinicians, we can assist bereaved individuals by doing the following. We validate their pain and distress related to the loss. We provide appropriate pharmacological therapy to support them through this time. We make bereaved patients aware of the many supportive therapies available and have ready a list of referrals, like grief support groups, whatever it is you have around you in your community. You want to have these supportive resources like ready to go on a paper, so they know exactly who to call. Utilizing the circle of caring model, community services that focus on grief, especially traumatic grief like miscarriage, death of a child at birth, death from violence or war. Those would be really traumatic life events, of course. So your church resources, family support, and other support services to deal with special issues, for example, like single parenting, may all be beneficial. Appropriate medical therapy should be given as indicated depending on the symptoms and the history of the patient. For example, a brief course of a short acting sedative may be appropriate during acute grief to induce not to, so we can induce sleep and get through the funeral and burial, especially when supportive interventions have not succeeded. The use of drugs like tranquilizers or alcohol, which can tend to numb emotions, should be discouraged, of course, because they can also make these particular patients actually more depressed. Antidepressant therapy may be considered for patients with particularly prolonged or complex grief reactions, even when it may be difficult to differentiate depression from a normal grief response. Clinical data suggests that selective serotonin reuptake inhibitors, or SSRIs, may be beneficial and assist the patient to mobilize the energy necessary to progress through the stages of mourning and grief. Obviously, specific counseling sessions for the bereaved may be extremely valuable and may assist in the prevention of pathological mourning or depressive reactions. So the bottom line is, guys, if a patient is really grieving, especially if they have any history of depression already, you can, of course, prescribe an SSRI or just to give them a little boost to get through this time, if the patient is willing. If not, then definitely use the non-pharmacological methods and get them to the support groups, get them counseling, whatever it is they are open to. Send them to their church, their ministers, their priests for support, spiritual support. Those kinds of things can really be very beneficial for these patients. Okay, substance use disorders, pathophysiology. Disease models include susceptibility variant as well as exposure constructs. So, this is why, how these patients become substance use users specifically. Diagnostic reasoning includes substance use disorders versus substance-induced disorders. And management in substance use disorders, the first goal is restoration of physical, psychological, and social well-being. Keep in mind the primary care provider has an obligation to inquire about, provide information about, and make appropriate referrals for substance-related or behavioral addictions. All agents in the substance use disorder, or SUD, category can cause tolerance, habituation, and physical dependence. The legal substances that fall into this category include tobacco, alcohol, and cannabis. Illicit substances include cocaine, opioids without medical prescription or necessity, hallucinogens, certain inhalants, stimulants such as methamphetamine, sedatives, hypnotics, and eloxic. They all may be prescribed for a variety of reasons on a short-term basis, but these substances can also lead to dependence and substance abuse, causing the user to seek the substance through illegal channels. The use of substances to enhance cognitive function as well as athletic performance, some of which are legal, all have the potential to veer for overuse. Caffeine is unique in that it is not classified as an SUD agent, but symptom criteria for intoxication and withdrawal are provided. Additionally, the DSM-5 includes another behavioral addiction, which they have included is gambling. There has been lobbying for inclusion of diagnosis for additional behavior addictions, such as internet shopping, but evidence is lacking for many of these diagnoses. So that's an interesting thought. But the bottom line is you want to ask and inquire with these patients, if they're having any issues. Screening questions that may uncover a substance abuse problem include: has anyone ever suggested that you may have an alcohol or drug problem? Or have you ever gotten into trouble because of alcohol or drugs? Keep in mind the epidemiology of substance use disorders. The highest prevalence rates are from ages 18 to 24. So this is your highest risk population in your practice. So when you want to just consider that when you have any of your patients coming in between the ages of 18 to 24, these are the people you want to start screening. Because the earlier we intervene and get these patients help, the better off they'll be forever. Another thing to consider is tobacco use is the leading preventable cause of death and disability. So again, let's make sure we're talking about smoking cessation and documenting on it at every single visit, okay? Alcohol is the primary substance of abuse and dependence, probably because it's one of the easiest drugs to get access to. So these are things to just keep in mind because you are going to want to be screening pretty much everybody, but specifically these high-risk populations when they come into practice. Okay, so another common psychosocial complaint that you may see in practice is intimate partner violence, or IPV. And this is a pattern of assaultive and coercive behaviors. It's aimed at establishing control over another. It could include physical, psychological, sexual, social isolation, stalking, deprivation, intimidation, threats. It's not associated with any ethnic group, religion, or socioeconomic level of education, employment, or sexual orientation. It goes across the board. There's nobody who is higher risk or less high risk. This can happen to anybody. Here in this table, I just wanted to point out to you common clinical presentations that you would see in terms of intimate partner violence in practice, and the different realms, whether it's physical, gynecological, or reproductive psychosocial issues that may present, psychosocial and situational. These are all the red flags that you need to be aware of. Typically, in intimate partner violence, the victims are a child, a woman, or an elderly person, and the typical perpetrator is a man in the case of partner abuse. A parent or another trusted adult in the case of child abuse, or it could be an adult child or other caregiver in the case of elder abuse. Although alcohol and substance abuse and a history of child abuse are important correlates of IPV, they do not cause or explain intimate partner violence. So the CDC gives us some tips here on preventing intimate partner violence. The CDC does have guidelines in terms of this, so just you want to check that out in terms of just education. Symptoms or behaviors that may signal abuse include exacerbation or poor control of chronic illnesses, sleep disturbances, chronic pain, or frequent unexplained appointment changes. Behavioral red flags are, number one, a patient who is reluctant to speak in front of her partner or gives evasive answers. And number two, an overly protective or controlling partner. Any patient presenting with multiple complaints or whose symptoms are not consistent with her history should be assessed for violence at least once and reassessed if she fails to respond to therapy appropriately. Exposure to intimate partner violence is frequently linked with mental health issues such as depression, anxiety, suicide attempts, and or substance abuse. Problems or injuries during pregnancy should also raise the level of suspicion, as should delays in seeking medical care. Any evidence of intimate partner violence requires full compliance with local reporting and referral laws. Local and state agencies for victims have established protocols and systems for providing services that include emergency housing, healthcare, foster care, and displacement counseling. Despite the significant incidence of IPV, there is still a shortage of referral services for violent offenders. Violent individuals who are motivated to stop their violence may benefit from community support groups. Local crisis services and police hotlines should be contacted to protect these victims of domestic violence. So remember, guys, this is all part of your role in this. If your patient's coming in, you're suspecting that they're a victim of intimate partner violence, you need to take the steps to get this patient into safety and get the local authorities involved to get these people help. Of course, you have to make sure the patient is willing and wants to, comply, wants this help, because sometimes they don't want help. That's a whole other issue. But in the meantime, you are mandated to report these things. You do want to make sure as well that you have the correct information and local contact info for these types of referral services for these particular patients. So victims of IPV should have the phone number and address for local emergency services, legal advocacy programs, and support groups, and how to be and they should also be informed of how to obtain this information if they don't want to take it at the time of the visit. Excuse me. Next, we're going to get into schizophrenia spectrum disorders. The epidemiology of schizophrenia is usually males, onset early 20s and late 20s in the females. It's chronic with functional impairments and identified risk factors, which we'll get into. The pathophysiology includes both genetic and environmental factors, and it does, in terms of how it affects the dopamine, It includes overstimulation and downregulation, which modulates both the positive and negative symptoms. Schizophrenia is among the most disabling and expensive mental illness, surpassed only by the substance use disorders and depression. The World Health Organization ranks schizophrenia as one of the top 15 illnesses contributing to the global burden of disease because the cost is staggering. For example, an analysis of insurance claims in the US found that the annual health related expenses of someone with chronic schizophrenia averaged more than $15,000. The cost of schizophrenia related treatment from 2004 to 2009 in the US increased from 9.4 billion to 11.5 million. Although the pathophysiology of schizophrenia is unknown, it's likely a syndrome comprising of multiple diseases that present with similar signs and symptoms. It definitely may run in families, and as already noted, living in an urban environment and having a male gender and a history of migration are associated with a slightly higher risk for developing the illness. Genetic factors and gene environment interactions together contribute more than 80% of the risk for developing schizophrenia. So really, genetic factors and gene environment interactions together are your highest risk factors for developing schizophrenia. Environmental factors associated with a higher likelihood of developing schizophrenia include cannabis use, prenatal infection or malnutrition, obstetric complications, and a history of late winter, early spring birth. So in terms of your positive symptoms refer to the active qualities of these symptoms that are abnormal and are synonymous with psychosis. Your positive symptoms include delusions, hallucinations, disorganized thinking, and grossly disorganized or abnormal behavior, also known as catatonia. Delusions are the hallmark of positive symptoms occurring in more than half of the patients. Delusions are fixed beliefs that are not amenable to change despite conflicting evidence. Now, in terms of your negative symptoms or your downregulation of dopamine, it represents a diminished or lack of normal characteristics, diminished emotional expression, and avolition. Diminished emotional expression encompasses reductions in the expression of face, eye contact, intonation of speech, and movements of the hands, head, and face that contribute to the emotion of speech. Avolition represents the decline in the motivated, self-initiated, purposeful activities. This encompasses loss of affective responsiveness, verbal expression, communication, personal and social motivation, and enjoyment. Primary negative symptoms can be resistant to treatment and closely related to functional outcome. Secondary negative symptoms may be routed in other manifestations, such as depression of the illness or treatment, including sedating antipsychotics. So here is a nice little concept map of what the clinical features of schizophrenia, how they present. People with schizophrenia often experience symptoms such as hearing internally generated voices, not heard by others, or believing that other people are reading their minds, controlling their thoughts, or plotting to harm them. These symptoms are very, very scary for these patients. So you have to really be gentle, non-judgmental, and extremely supportive, okay? Because you don't want to scare them away or make things worse and make them feel like they're doing something wrong by even, talking about it to somebody and telling them that they're experiencing these things. These symptoms may leave these patients fearful and withdrawn and reluctant to engage in treatment or non-adherent to treatment. Because of its sometimes disruptive symptoms, a diagnosis of schizophrenia can have serious implications for patients and families. Schizophrenia is a serious disorder of the mind and brain, but it is also highly treatable. And although there is no cure as of 2018 for schizophrenia, the treatment success rate with antipsychotic medications and psychosocial therapies can be high. So there is a good success rate as long as they are compliant with their medications and they really are proactive in their treatment plan. So diagnostic reasoning includes a complete history and physical, neurological, and mental status examination, CBC with differential electrolytes, your liver profile, thyroid profile, drug and alcohol toxicology, and pregnancy testing. You also want to assess for any infectious diseases, including screening for syphilis, HIV, and Hep C. We also want to test for any heavy metals, do an EEG, brain imaging with an MRI or CT as needed. Um, we want to make sure in terms of follow-up, we reduce the effects of stigmatization. We don't want them to feel like they're, suddenly going to be ostracized because of their psychosocial issues or disease, I should say. We want to make sure these patients are adhering to their medication and following up with laboratory testing as indicated. In terms of education, we're just trying to optimize their functional status. We want to educate both the patients and the caregivers on the Clozaril side effects and what to report immediately, including any types of infections. Early intervention and early use of medications lead to better medical outcomes for these individuals. Recent research increasingly shows that the disease process of schizophrenia gradually and significantly damages the individual's brain, and that earlier treatments seem to result in less damage over time. The earlier someone with schizophrenia is diagnosed and stabilized on treatment, the better the long-term prognosis for their illness. There is a higher incidence of co-occurring disorders in those with schizophrenia, such as depressive disorders, anxiety, social anxiety, post-traumatic stress, and obsessive compulsive disorders, as well as alcohol and substance abuse. They also have higher rates of metabolic and neurological problems. The rate of suicide is higher in those with schizophrenia. Teens with schizophrenia have approximately a 50% risk of attempted suicide. About 10% of all completed suicides are by people with schizophrenia, and about 5% of all people with schizophrenia commit suicide. So really lots of education, guys, especially on if their mood or depression becomes that much more severe, to please have them reach out to you or whoever it is you want, have resources for them to reach out to. The disease course of schizophrenia is variable, with some patients exhibiting only mild symptoms, while others follow a chronic course resulting in functional impairment, including an inability to maintain independent housing and gainful employment, and they have social deficits. Poor engagement in their health maintenance initiatives, such as cancer screening, exercise, nutrition, tobacco cessation, and identification of other comorbid chronic medical diseases, also obviously can play a role in their poor outcomes. So here's your psychosocial treatments for schizophrenia. We have our cognitive behavioral therapy to help people develop skills and strategies for becoming and staying healthy. Cognitive remediation, using training and practice to improve memory and attention. We have psychoeducation, helping people understand the causes of their illness. Social skills and life skills training, as well as family support and education and family counseling. And honestly, guys, these treatments are not just for schizophrenia. This goes hand in hand for pretty much all of the treatments of all the psychosocial disorders. So just familiarize yourself specifically with the cognitive behavioral therapy. It's very big and it's very effective. Okay, now let's get into MDD, major depressive disorder. This is characterized by severe negative change in mood, thinking, and behavior. Up to 20% of the population suffers from MDD. It's usually found in adults over the age of 65, and there's a higher rate in women. It is a recurrent disorder. It comes and goes, fluctuates depending on situation, environment, and hormones, of course. Comorbidities include anxiety, cardiac issues, and diabetes. Here we have in Table 1 the symptoms of major depressive disorder based on the DSM-5. So actually, I think it's the DSM-4. But anyway, depression can cause great psychological pain, prompting many depressed persons to consider any solution that they think may bring relief. Patients may have difficulty describing their pain and may make vague references to hurting or feeling bad. A study of women with postpartum depression revealed that various descriptors with which individuals may characterize signs and symptoms associated with depression. So you should look at that in your book. In terms of education for patients with major depressive disorder, we want to make sure we're educating them on the danger signs and symptoms, which include hallucinations or delusions, severe adverse effects from their antidepressant medications, which include severe urinary retention, fluctuation in their blood pressure, seizures, or any kind of cardiac complications, suicidal thoughts, and extreme self-care deficits, like they're not being able to take care of their basic needs by themselves. These are all danger signs that either the patient or the significant others should make sure to call 911 or call anybody for help. Okay, but emergency or crisis service numbers, again, should be something you have readily available to your patients. And any concerns that they may have, you should just give them a copy of this when they're leaving. Keep in mind also something that's very interesting. Many patients may experience an increase in suicidal thoughts or urges during the first few weeks of treatment. When they first start their medications that you start them on, there is a lot of research that shows that the first few weeks that they're on the treatment, their risk for suicide does go up. So make sure you educate patients on that they need to be aware of that. Okay, bipolar disorder, another mood disorder. Bipolar disorder is commonly seen in the primary care setting and is frequently mistaken for other conditions, often MDD or major depressive disorder. The spectrum of bipolar disorder includes bipolar disorder 1, in which the essential feature is mania, bipolar 2, characterized by recurrent moods of hypomania or a persistent period of excitement or hyperactivity with a moderate change in behavior, and depression. Or we have our cyclothymic disorder, characterized by alternating cycles of hypomania and depressive episodes, but of lesser severity than those of manic or major depressive disorders. The three major categories, bipolar disorder 1, bipolar disorder 2, and cyclothymic disorder, are all discussed here in this slide. We have to be able to distinguish between the depressive episodes occurring in the context of unipolar depression and bipolar mood disorders, because patients with bipolar disorder require mood stabilizing pharmacological therapy, and their symptoms may worsen with antidepressant monotherapy. So you want to make sure you're differentiating if the patient has MDD versus BD, okay? Emerging data from a variety of sources has confirmed a typical delay between symptom onset and diagnosis of 5 to 10 years, with patients seeing an average of 4 healthcare providers before the correct diagnosis is given. MDD is a common misdiagnosis, the treatment for which, like we said before, antidepressant monotherapy, may induce mania in bipolar disorder patients. Over a 5-year period, 85% of patients with BD will have a relapse after one affective episode. During inter-episode periods, half of the patients may experience subsyndromal symptoms such as cognitive impairment and impulsivity. Inappropriate pharmacological treatment for bipolar disorder is associated with increases in morbidity and mortality and with suicide. Please, if you feel that your patients have anything that represents this type of disorder, you want to get them screened immediately and get them treated as soon as you can. The following mnemonic, dig fast, is useful for identifying bipolar disorder. And dig stands for D for dig stands for distractibility. I stands for insomnia or a decreased need for sleep. G for dig stands for grandiosity, or in this inflated sense of self or inflated self-esteem. The F in dig fast stands for flight of ideas, which includes racing thoughts, or negative for rumination. The A includes activities, which are increased and goal-directed. The speech, S is for speech, which is pressured with increased talkativeness. And then the T, thoughtlessness, which is pleasure-seeking activities that show poor judgment, such as spending sprees, sexual indiscretions, reckless driving, or arguments if irritable. So again, make sure you review that mnemonic for identifying bipolar disorder. Dig fast, okay? Distractibility, insomnia, grandiosity, flight of ideas, activities, speech, thoughtlessness. Those are your mnemonics for dig fast. Okay, next we're going to get into suicide. With all of these disorders, the risk for suicide is always higher, and this is something we're always very concerned about. We want to make sure we know suicide is the 10th leading cause of death in the US. It's the second leading cause of death in the adolescents population. It's 3.3 times more common in men, and 10 to 20% eventually succeed. 11 to 51% of the population that try to commit suicide have physical illnesses present. And it's also known that a family history of suicide
It's 9 o'clock.
puts you at a higher risk for having that the possibility of suicide. In 2015, more than 44,000 Americans committed suicide, making it the 10th leading cause of death in the country. Since 2005, the suicide rate has increased every year. I'm assuming because of COVID over the last few years, those numbers have probably drastically gone up. Several terms are associated with suicidal behavior. Complete suicide refers to self-inflicted death. Attempted suicide describes potentially lethal acts that did not result in death. Aborted suicide indicates potentially suicidal behavior that was stopped before the action was completed. Suicidal ideation denotes thoughts of causing one's own demise, and it can be accompanied by planning, intent, rehearsals, and obtaining the means to suicide. Parasuicidal behavior describes patients who injure themselves non-lethal, occasionally attention-seeking gestures such as superficial cuts on wrists, but who do not wish to die. The behavior is obviously a risk factor for suicide. The big thing with suicide is you need to know the science, right? So again, here is National Institute of Health, Mental Health. They have lots of resources on this. They're all about suicide prevention. Understand acute risk factors of suicide include severe anxiety, rumination, insomnia, depression with psychotic features, and alcohol or other substance abuse. A prior suicide attempt is the most important risk factor for suicide. I'll repeat that. A prior suicide attempt is the most important risk factor for suicide. The likelihood is they will try it again if they've already done it. So those are the patients you need to be most concerned about. As such, suicide screening tools often focus on previous attempts or intent to commit suicide with various supportive items, including demographic information, level of social support, and coexisting mental health disorders. Because the goal of a suicide scale is to prevent completion, the sensitivity of the scale must be high so as not to miss a potential suicide. This may result in an over-reliance on a history of suicide attempts when evaluating for the risk of suicide. The modified SAD persona scale, so guys, again, there's a mnemonic SAD personas, which is a scale, has an administration time of 1 to 2 minutes, and the author suggests using this as a rapid screening tool for non-psychiatrists to obtain the objective information necessary to make an initial assessment of suicidality. For adolescents and young adults, aged 10 to 24, the Ask Suicide Screening Questions Toolkit is a free resource for medical settings that can help clinicians identify you at risk for suicide. The ASQ, or Ask Suicide Questions, is a set of 4 screening questions that takes 20 seconds to administer. Now, in terms of your SAD person's mnemonic, here's what it stands for. SAD is S is for sex, A is for age, D is for depression. SAD person, so persons, P is for previous attempt, E is for ethanol abuse, R is for rational thinking loss, and S is for social support loss. So these are risk factors in a mnemonic that you could use to evaluate a person's suicide risk. And you want to consider your risk factors within the context of the clinical presentation. So really figure out like what happened or what's going on currently with your patient in their life that would possibly have led to this level of depression and possible risk for suicide. Make sure everything that you are doing in terms of intervention and screening and assessment is documented clearly, guys, okay? Okay, anxiety, stress, and trauma-related disorders. Here we're getting into general anxiety disorder, which is excessive, difficult to control thoughts. It's more common in women, and it's 60% of these patients also have a comorbidity of depression. In terms of panic disorder, it's very frequent in emergency settings. It's twice as frequent in women, and it peaks at age 25, and then it's pretty consistent from the ages of 35 to 44. Keep in mind, generalized anxiety disorder, or GAD, is characterized by excessive worry over 6 months about multiple concerns that are difficult to control. Anxiety disorders are the most prevalent psychiatric syndrome in the United States population and commonly presents in your primary care settings. Persons with generalized anxiety disorder experience a range of upsetting physical symptoms along with hyperarousal and insomnia. A diagnosis of GAD requires evidence of disrupted or impaired occupational or social functioning. GAD, or generalized anxiety disorder, is more disruptive than normal anxiety, which is characterized by apprehension and mild physical symptoms of upset, such as headaches. From 50 to 90% of patients with GAD have another comorbidity mental disorder, most commonly, of course, depression. So a lot of these patients with generalized anxiety disorder have the comorbidity of depression as well. Now, panic disorder, on the other hand, typically presents in young adulthood, is also a disabling condition, and can impair an individual's social, family, and work life. Panic disorder symptoms are recurrent, intense, short episodes of panic-level psychological and physical symptoms of anxiety. The initial panic episode must be spontaneous and unexpected, and cannot occur when the person is in the focus of others' attention, such as when speaking in front of an audience. A combination of sudden onset and severity of panic symptoms creates secondary symptoms of fear. These secondary fear symptoms essentially define this disorder, because fear compels the patient with panic disorder to seek emergency health services repeatedly. To the patient, these panic symptoms, are life-threatening and signal a serious health problem or an impending nervous breakdown. These patients endure an unshakable sense of doom and danger that they cannot define. It's very scary, these poor patients. Cognitive behavioral therapy is the first line in treatment for panic disorders, and useful adjuncts are self-help, cognitive-based therapy books and self-help programs. Patients who receive cognitive behavioral therapy have longer periods of remissions and long-term benefits. It's also, CBT is also useful to facilitate the withdrawal from the benzos, which are often used for immediate symptom relief in panic disorder. Hypnosis and alternative therapies like yoga and meditation are also very helpful combined therapies for generalized anxiety disorder. However, they're still not as effective as the cognitive behavioral therapy. So definitely make sure these patients get enrolled in that type of therapy. Okay, we also have PTSD and sexual assault as also trauma-related disorders. In terms of PTSD, they must have one of these symptom categories, which includes intrusive, avoidant, or hyperarousal. PTSD is twice as frequent in women. It's a syndrome that develops after a person witnesses, participates in, or experiences direct exposure to actual or threatened trauma, such as death, threatened death, serious injury, or an event like sexual violence, and or learning that a relative or close friend was exposed to a trauma. Additionally, indirect exposure to adverse details of the trauma, usually in the course of professional duties, such as first responders and medics, may also lead to the development of PTSD. Think of all of our firemen and all of our medical professionals during 9/11 who experienced PTSD. This exposure can be repeated or a one-time event. The reaction to this experience is typically fear and helplessness, reliving the event over and over and trying to avoid being reminded of it. PTSD symptoms are responses to experiences that are overwhelming, for example, war, torture, natural disasters, terrorism, assault, rape, fires, anything crazy out of the norm is something that is probably going to cause symptoms of recurrence to come back to these patients. For instance, specifically our veterans, any of them who have had any serious experiences overseas, they have a lot of issues with PTSD. Sexual assault is forced sexual behavior against will or lack of consent. The National Institute of Justice defines it as any unwanted sexual behavior against the person's will or lack of consent due to age, disability, or being under the influence of alcohol or drugs. Sexual assault could be an actual event or a threat of the following: any intentional touching of the victim's genitals, anus, groin, or breasts, exposure to exhibitionism, undesired exposure to pornography, public displays of images that were taken in private content or when the victim was unaware. Those are all sexual assault included in sexual assaults. Obsessive compulsive disorder. So, back to this before I forget. So it's in terms of sexual assault, just like IVP or partner Oh, I forgot what it was called. IVP. Let's see. Hold on. Let's go back to that. Okay. Oh, I'm sorry. Intimate partner violence. So just like intimate partner violence, as well as sexual assault, we as healthcare professionals are mandated to report these things. So make sure you have those resources again within your practice to have those readily available in case anybody comes in with reports of sexual assault. Obsessive compulsive disorders, OCD. So OCD is characterized by the presence of obsessions, compulsions, or both. It's early onset in men, usually later onset in women. It can be chronic and it does have genetic components. OCD is grouped diagnostically with several related disorders, including our body dysmorphic disorder, which we'll get into, hoarding disorder, hair pulling disorder, and excoriation disorder, also known as skin picking disorder, as well as substance, medication, and or other medical conditions, including obsessive compulsive disorders. The linking feature of these ailments is repetitive behaviors, though otherwise they have differentiating presentations, heritability, and treatments. So here in this box, I just wanted to make sure we reviewed the first line treatments for obsessive compulsive disorder, which again, they use the cognitive behavioral therapy, which is fantastic. Then they use your SSRIs, and they break down for you here your dosages as well as what else you would include, including just reminders and education based on each medication. So for instance, your escitalopram definitely can lead to drowsiness as well as weight gain. In your citalopram, remember higher doses require your ECG monitoring. Here's an algorithm to help assess the severity of OCD and what you would do in terms of options. So here we would do, if we were concerned that we're working with a patient with severe OCD, that's when we're going to go ahead and initiate a psychiatric referral. And that goes honestly true for all of these disorders, guys. You know, you're going to treat it in primary care, but you're also going to get these patients referred to counseling, social workers, psychiatrists, psychologists, whatever they need to get this managed and under control for long-term purposes. You want to go ahead and start making those referrals. Screening questions for OCD only take a few minutes. If the patient responds positively to one or more of the following questions, that's when you're going to start to want to consider making a more formal diagnostic assessment and treatment plan for them. So things you would want to consider asking them would be, are you ever bothered by frequent thoughts that are senseless but you can't get out of your head? And how do you deal with them? Do you spend a lot of time worrying about germs? Do you wash your hands a lot? Do you find yourself counting or repeating things over and over? Do you repeatedly check things like locks, plugs, or burners? Do you arrange things in a specific order? And how do you feel if someone messes them up? How much time do you spend a day doing this? These are screening questions that you should be asking your patient. How does it affect your day-to-day life? Have you stopped going to certain places or doing certain things? When these patients start responding that these things are literally taking over their life, these habits or these repetitive thoughts and actions, that's when they really are going to be considered moderate to severe. Okay, another disorder that falls under the OCD umbrella is body dysmorphic disorder. And this is the clinical features of BDD include preoccupation with perceived defects or flaws in the physical appearance, leading to repetitive behaviors or mental acts. Its distinguishing characteristics include obsessions and compulsions, such as checking, and are limited to perceived physical defects. Patients often have a very poor insight to how they actually look. There are no FDA-approved treatments for BDD. However, their high-dose SSRIs are considered the first-line pharmacological treatment for it. Agents like medications for this would include fluoxetine, citalopram, escitalopram. Trial duration is longer than for MDD or major depressive disorder. it's at least 12 to 16 weeks for BDD. Helpful screening questions to assess for body dysmorphic disorder include: do you think there's anything wrong with the way you look? How does anybody else notice? Do you think you look unattractive, ugly, or even hideous? How long do you spend looking in the mirror on grooming? Have you stopped going out? Do you feel isolated? This is called the Yale. Oh, so these are just screening questions, but they have a Yale Brown obsessive compulsive scale to assess for the BDD. And they really use that. They find it to be a very reliable and valid tool to help identify the severity of BDD. So make sure you review that scale. It's called the Yale Brown Obsessive Compulsive Scale. It's in your textbook. Next, we're almost done, guys. This is the last one. Hoarding disorder. This is also falls under the obsessive compulsive disorder umbrella. The hoarding disorder is estimated to affect 1.5% of the population. And I don't know about you guys, but I have seen more than a few patients that live in these types of conditions. It's so awful for them. I mean, it's just unbelievable. But it's more prevalent in unmarried, divorced individuals. The majority of these patients have comorbid psychiatric illnesses. And the prominent feature of this is a cluttered home due to difficulty to discard commonplace items and can result in definitely hazardous living conditions. In the past, hoarding was considered a subtype of OCD or a symptom of obsessive compulsive personality disorder, but it's now recognized as a distinct diagnostic entity. Patients usually do not present complaining of hoarding, but rather may be brought to clinical attention by a family member or friend distressed by the individual's possessions and the state of their living environment. So this is a very tricky situation, guys, because these patients, even though they have this disorder, they may still be of sound mind. So we can't just go in and pull them from their house because of this. What you have to kind of look at is the patient now becoming unsafe because of the state of the home? And that's what I had to deal with as a visiting nurse. You can't, you can call Adult Protective Services to come in, but technically they can't just remove a patient from the house because they have a lot of stuff. It's, what happens is there a safety concern? Does the patient now keep falling because they keep tripping over all the stuff on the floor? Do they have rodents in the house now that are a concern? These are the things that will eventually end up happening, and suddenly this disorder then takes over their life, and then they have to be placed. It's really terrible. So if this is something that you're presented with, you want to definitely get some home care services, some kind of community services to the patient's home to help them see if they can do anything for this patient. All right, that's it for this week's part of the psychosocial problems. Next week, we will focus on chapter 70, 71, and 81. It doesn't look like much, but when you break down these chapters, there's actually quite a bit. We will also go more into the guidelines for each of those things in your cash textbook for next week. I hope this was helpful, guys. I hope you're having a great week. You are doing so great. We're already going into week 12 now, or actually next week this is week 12. The next one will be 13. We're almost done, guys. So if you have any questions or you wanted to talk to me, please feel free to email me. Otherwise, keep up the great work, and I'll see you next week.